Very good morning to everybody, and welcome to the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds today. Today is a special day because this is also a part of our George P. Noon conference under the J.C. Walter Jr. Transplant Center. With no further ado, today we have a special guest, and Dr. Mann is no stranger to Houston and our institution. And I jumped at the honor of introducing him, except I knew Dr. Guillermo Torre, who's here with me, who's probably going to do a better job. And for many who know Dr. Torre, he's, for a lack of a better word, I call him the godfather of our program, a phenomenal gentleman, my mentor and friend. And for those of you who know him, yes, he's still a part of our institution. And no, he's not the president of Mexico yet. And with that, I will transition over to Dr. Torre to introduce Dr. Mann.
Arvind, thank you very much. It's really a great pleasure to be here today. First, because the transplant program has had a tremendous impact in the Houston area, and it's all under the influence of people like Dr. DeBakey, Dr. Noon, and also because of Dr. Mann's work and presence. And I'm going to take a couple of minutes just to share with you a little bit of his background that certainly needs no introduction for all of us that have studied and lived heart failure for many, many years. But Doug finished medicine from Temple, did cardiology fellowship at the University of San Diego, but more importantly, came over to Houston many, many years ago. And at that time, I was actually in medicine, and Doug came over to the VA to join the faculty at Baylor College of Medicine and the great program that we had at that time. And I had an interest in doing research. I had done research for many, many years in immunology, and this is going back almost 30 years. And Doug, I think, was one of the very few individuals in cardiology that had an interest in inflammation and immunology. And I had a brief conversation with him. I was pursuing my research years, and his passion for research was infectious, more infectious than COVID today. And that led me to work with him for many years. And I have the honor to be one of the very first research fellows that worked with him. And I was so happy, and that has marked my career for many years. But I think I shared that with you and with the audience because I think that's been perhaps the signature for Doug's career through the years. I think that one of the things that he enjoys the most is to mentor people, to help them proceed in his or their path in career. And many of us that are here today have enjoyed that from him. He's published over 300 papers. He's been member of the editorial board of many different journals. He recently received the Lifetime Achievement Award for the Heart Failure Society of America, has grants, continuous grants for many years, and I think more recently has also dedicated a lot of his time to be the editor of the JAG Basic Translational Journal, which really exemplifies everything that he has done and what he wants to do the next very successful part of his career. And I said that because recently stepped out from the job of Chief Cardiology at Washington University to continue his career in basic and translation research. So Doug, I am very happy that you're joining us today, and you will continue to be, for me and many others, an example in life, career, and your passion to pursue research and medicine has been an example to all of us. Thank you for sharing with us this next 45 minutes on what's been the passion of your life and many of us. Thank you.
So I want to begin by thanking Arvind and Guillermo for inviting me to speak. I wish I could be there in person today. We live in these incredibly strange times. And I also want to thank Guillermo for the generous introduction. I think I learned more from him than he from me. But it's been phenomenal, the relationships that one has with trainees, many of whom were in the medical center. So I'm going to try to begin my talk today by sharing the screen. That worked. And then the next thing is to see if the slides will advance. So the topic I was given today is heart failure is a progressive disease. How to keep patients from slipping the stages is recovery the answer? And when I saw the title, I said, well, recovery is really always the answer. So I'm going to briefly talk about this concept of heart failure with a recovered EF, which is really an interesting journey for me as a heart failure biologist. Pardon my voice. So we know that heart failure begins after an initial index event causes a decline in pumping capacity of the heart, and the heart undergoes a process known as left ventricular remodeling. Over the last 30 or so years, we've become really good at implementing a number of medical and device therapies. This in turn will lead to a recovery of left ventricular function. This recovery can be complete with the EF greater than 50%. It can also be partial with a recovery greater than 40%. And then there are a group of patients in whom there's really no functional recovery. And these are the patients that go on to advanced heart failure and transplant. The topic of my talk today will really be this group of patients here who I think even as early as 5 years ago, we would have claimed victory and thought that we'd cured them of their heart failure. And as it turns out, this group of patients really has an interesting biology that's distinct, but they continue to develop heart failure for reasons that are unclear. So I was fortunate enough to be part of an expert panel commissioned by Dr. Fuster, where we really tried to drill into this group of patients because there are no practice guidelines for this group of patients because there really are no data. So the panel suggested that we use the nomenclature heart failure recovered EF. The R for me stands for reduced, implying that the patients at one point had low ejection fractions and had remodeling. The working definition that we proposed, and again, this is not in practice guidelines, we hope it gets into them, but there would be a documented LVEF less than 40%, that the ejection fraction increase greater than 10%. In the literature, there are also cutoffs of 5. We thought this was beyond the range of intra-observer variability. If there should be a second measurement of left ventricular ejection fraction at least 3 to 6 months out from this baseline recovery to get away from hemodynamic changes or diuretic-induced changes. And we think that really assessing the left ventricular ejection fraction is key. So what about the epidemiology of these patients with recovered left ventricular ejection fraction? This slide just shows the epidemiology of a group of patients with recovered left ventricular ejection fraction. Turns out there's some great examples in nature of patients who will get transient LV dysfunction and then recover completely. They can be grouped really into 3 separate groups: toxic insults, inflammation, which is what Guillermo and I have studied for 30 years now, and then this other class of abnormal energetics. The best example of this probably is tachycardia-induced cardiomyopathy. The other group of patients with toxic insults today, it's probably most likely chemotherapy. We know that a number of the drugs that we use to treat patients with advanced cancers will drop EF. If the medicines are stopped, the ejection fraction comes back. And then we know also that a certain percentage of peripartum patients, and then even patients with myocarditis, will recover their left ventricular ejection fraction. So many years ago, I tortured Mike Gevirtz into doing this exhaustive summary of the literature with me. And what we did was to go through every paper at that time that had been published on the group of patients that I just discussed. And we looked at 2 things. What was their final ejection fraction after they recovered? Did they completely normalize? And did they improve by at least 10%? So this would be a modern day definition of heart failure with recovered EF. If you look on the back bars here, these are the people who improved their ejection fraction by more than 10%. I have an error bar here for chemotherapy because depending on the chemotherapy, the ranges are different. But you can see here that most forms of spontaneous recovery of ejection fraction, at least 50, more likely 80%, do recover EF by more than 10%. However, if you look at the front bar, the orange bars here, not all of them normalize their left ventricular structure and function. So the energetic groups are the most likely. Again, here the hit to the heart is the least. And if one then goes and looks at viral myocarditis or postpartum or another group of patients with recent onset cardiomyopathy, you can see here the ejection fraction really doesn't normalize in the great majority of patients. This is a slide from the Brown-Welch Companion to Heart Disease, which I edit. And this just shows that every single FDA-approved therapy that we have for treating heart failure, there's some degree of reverse remodeling, whether it's ACE inhibitors, beta blockers, CRT, or left ventricular assist devices, or CRT. All of these devices in part work by causing reverse remodeling. So what about the durability of these responses? So after the ejection fraction improves, most of us would consider that it's game over, that we've done our job, and the patient should be, in essence, cured, or at least not have recurrent heart failure. Turns out that's not the case. So I want to briefly summarize some data that came from the WashU Heart Failure Registry. When I moved from the medical center to St. Louis, the NIH was giving out dollars. This was the era of the 2008-2009 financial collapse. So the NIH, basically, you could write any grant you wanted, and they were giving money as part of the stimulus plan. So we set up a registry, and I was agnostic in the registry about what the ejection fraction was. I said, just go collect as many patients as you can and then do 2-year follow-up. So we were able to enroll about 1,100 patients. The majority had heart failure reduced EF. Some had heart failure preserved. And then there was a resident who was interested in getting a letter for fellowship. So I asked Ashish, I said, why don't you just go look in this group of people who are mid-range EF? And this is at a time before it became a popular subject. And I said, figure out which of these patients had a reduced ejection fraction before they came in the registry, which had preserved ejection fraction, and which were in the middle. And as you can see here, this group of mid-range EF people, most of them had heart failure reduced EF, got better on medical therapy, and then we did longitudinal follow-up on these patients. So this is event-free survival. So we looked at death, transplant, or cardiac hospitalizations, and we had pretty good follow-up for 2 years. You can see that the mid-range EF people do better than reduced EF. And this is probably a no-brainer for the heart failure mafia. These are responders to medical therapy, so of course they're going to do better than non-responders. The more interesting part of the data to me was if you look at the same events and then compare it to heart failure preserved EF, these are age and gender matched patients, you can see that they have about the same heart failure events. So although the fact that they've had partial recovery of function and they're on guideline-directed medical therapy, they still continue to have heart failure events. So we've now taken this question one step further, and what we did was we did a large-scale proteomic study on these same patients I just showed you, and this was just published in JACC. And there's some really interesting findings I want to share with you this morning. So first of all, we had a group of patients in our heart failure registry. As I said, some had reduced, some had preserved, some had mid-range. We stratified them by their left ventricular ejection fractions, as I showed you previously. We had blood draws on all these patients at baseline, and then we used an Aptamer-based proteomics analysis, and I'll explain this on the next slide. So we just did a large-scale proteomic survey, about 1,100 proteins on each of these people, and then we did some bioinformatic analysis. So the way in which the SomaLogic scan works is they've designed a number of DNA aptamers. So this is DNA that will bind to specific proteins. They then modify the aptamers so they can be bound to a variety of different substrates and then released. The bottom line is that this will allow you to simultaneously measure 1,100 proteins in one group. The downside is that it doesn't give you a level of a protein like we're used to reading in labs, but it does allow you to compare levels of proteins between groups. So I'm going to show you comparisons of these SomaScan in HFrEF, HFpEF, and heart failure mid-range. If there are no differences between the groups, the bar will look gray. If, on the other hand, there are increases in protein, they'll be shown as red, and there are decreases in protein levels between groups, they'll be shown in blue. So the first thing we did was to compare HFrEF versus HFpEF, and you can see there's a fair amount of red and blue here, indicating that there are a lot of differences between these two groups of heart failure patients. Not a surprise to those of us who care for these patients, they respond to medicines completely differently. If, on the other hand, you look at heart failure mid-range EF versus heart failure preserved, remember, they have the same kind of heart failure events. You can see there's a lot more gray. So at least at the proteomic level, these patients look more similar than HFrEF and HFpEF. And then more striking, perhaps, if you compare HFrEF, and remember, the majority of these people had heart failure mid-range EF, heart failure reduced. There are a lot of differences. And this group of people largely came from heart failure reduced EF. So this concept is really illustrated better in these so-called PCA plots, which allows you to group the data very simply by their first principle variance. So if you look at the HFrEF, it's shown by this cloud here. HFpEF is shown by this cloud here. And then the heart failure mid-range EF is really distinctly different. So they're different profile, but overlapping heart failure preserved EF. And then what we did was to split this group out into the ones that actually recovered their EF and the ones that didn't recover their EF. And probably not surprisingly, the not recovered are between HFpEF and HFrEF. But again, this heart failure mid-range EF group that improved is distinctly different, at least at the proteomic level. And again, I've argued for years that these patients still have heart failure, right? And you can see that the heart failure proteome overlaps other heart failure proteomes. So again, the concept is they're distinct, but they have several features that are very similar to heart failure. Okay, what about the epidemiology of people who completely recover their EF? These are patients that Arvind and Guillermo would say, we've done a great job here. They've completely reversed remodeled. Injection fractions are completely improved. There's a paper by Bazare. Jim Fang was the senior author. They used a very similar database to the one that we had developed at WashU. It came from Penn. And what they did was to look at people with a reduced EF, they're shown in purple, patients with a recovered EF, so they were reduced, completely recovered, they're shown in green, and then there's the heart failure preserved EF. So if one looks at probability of death, transplant, or VAD, the reduced EFs that don't recover have the worst outcome, not surprising, and the ones who recover on medical therapy do much better from a death and heart failure standpoint. Again, these are responders to guideline-directed medical therapy. This is a no-brainer. More striking to us was the fact that the heart failure events, they're coming in with recurrent heart failure, looks a lot like heart failure preserved EF. So this looked almost identical to our data that we've seen in the heart failure mid-range. So again, although they completely recover their ejection fractions, they still have recurrent heart failure events. So another paper by Merlo and colleagues in Italy, and they have a very nice group of patients with dilated cardiomyopathy that's exquisitely phenotyped with MRI. They went into their database to find a group of patients who had completely recovered their EF on guideline medical therapy. Only 15% of their cohort met this definition, and then they followed them longitudinally. The interesting thing was, of these people, and no heart failure doc would argue that they had normal left ventricular structure and function, about 40% of these people develop recurrent heart failure events when followed over time. So most recently, a paper by Lupon, and this group is from Spain. They also followed serially left ventricular ejection fraction, showed that the non-ischemics initially will recover, but then deteriorate. And also not surprising, the ischemics recover a little bit more, but not as much as the dilated. But again, shown here, there's this U-shaped curve that characterizes patients, even though they're on adequate medical therapy. So the question then becomes, what's going on here? So a number of years ago, I was at a Gordon conference, and I was with Dan Burkhoff, and this is when the LVAD mafia was claiming that all these patients were recovering, and then they would come back in the hospital in a couple months. And so I asked Dan, I said, do you think recovery exists? And he said, I don't know. So together we worked on this sort of construct of remission and recovery. But we asked the question is, what's different about the ventricle? These are the same size ventricle, but what's different about this ventricle than this ventricle? Are there differences in the cardiac myocytes, the myocardium, or the left ventricular geometry that would allow you to predict who these patients are? So, at the time, we didn't know what to call this. So I wanted to be able to all patients who truly recovered and never needed to see a doctor again, that would, to me, would be recovery. And then we coined this term remission. Dr. Frazier insists that I stole this from him. I don't know where it came from, but the concept, I think, that these patients remain asymptomatic but are likely to develop heart failure is the thing that I think remission captures. So the question is why? So at the end of the day, I'm a heart failure biologist, and I want to walk you through some of the reasons why I think this occurs and then make some recommendations for doctors. So this is my sort of construct for understanding how the ventricle works. I look at changes in myocytes, changes in the myocardium, and changes in geometry. The first thing is that despite the fact that the heart gets smaller and may contract better, the transcriptional profile in these hearts never goes back to normal. And this was actually known by Ken Margulies a number of years ago. So this is patients with dilated cardiomyopathy, had LVADs at WashU, and then we did RNA-seq on these patients. Again, I'm just going to focus your attention on these PCA plots. These are the dilated cardiomyopathy signatures. These are the non-failing, and you can see that people that are supported by LVADs, all of these patients had reverse remodeling and the ventricles got smaller. Their gene profile is somewhere in between. So again, they're not normal, but they get closer to normal. A really interesting study. So if you just go through and look at which components of the myocyte recover, you can see here, these are reverse genes, not a lot of activity there. These are the persistently dysfunctional genes, the ones that stay abnormal. Only the sarcomeric genes are the ones that reverse remodel here. And that probably explains in part why contractility returns. And again, just summarized here, you can see that for virtually all aspects of the myocyte, matrix, integrin, metabolism, EC coupling, they remain persistently dysregulated. But however, the sarcomere does improve. Another really interesting study by Arvind out in Colorado, what they did was to take myocytes from non-failing hearts, failing hearts pre-VAD, and then myocytes from the same patient post-VAD. They take the myocytes, isolate them, suspend them between two tweezers that can measure the tension. They strip the sarcolemma off the cell, add calcium, and they can generate like these force curves. So you can see non-failing, fairly good 15 millinewtons of force. Failing, not surprisingly, the myocytes are depressed. And then post-LVAD, they improve significantly. However, they're still significantly depressed when compared to non-failing. So again, the idea is the myocytes are better, but they are not normal. Now, what about myocardial alterations? If one goes and looks at the matrix, there are a number of changes that occur in the matrix, and Guillermo, I know, has done work on this. After VAD, there's a reversal of the matrix abnormalities, and part of that is driven by the medical therapies. But there are still some underlying abnormalities of collagen, and no one's really looked at the 3D weave. We've been good about quantifying the amount, but now not how it's organized. So the matrix is not completely normal, although it moves more towards normal. I think one of the more interesting things was the geometry, which I had always assumed normalizes, really doesn't completely normalize. This is a study from a colleague of Dan Burkhoff's. What they did was to take human hearts at the time of transplant and do pressure volume curves on them. So they must have had a cardiology fellow who could carry buckets and buckets of buffer to perfuse these hearts. But what they do is show that the pressure volume curve, normal patients here, the LVAD supported are shown by the dark line. So the pressure volume curves are completely normalized. These are the pressure volume curves from the failing hearts shifted outward to the right. We know that from years of studies. But again, on LVAD, they completely normalize. Most of us in the physiology world would say this is a perfect outcome. However, what they showed in the paper is that although the dimensions normalize, the long axis and the short axis normalize, the R to H ratio does not normalize. So this is really a poor man's wall stress. Although the ventricles are smaller and the longitudinal and AP directions, they don't normalize their wall stress. The wall thickness never comes back to normal. So now you have a myocyte that has an abnormal transcriptional profile. does not contract completely normally. The matrix that it's embedded in is not completely normal, and the ventricle can't normalize wall stress. So it's perhaps not surprising that these hearts, when they're stressed, will redevelop heart failure. So this is a statement that took probably 10 years for me to figure out at least, but reverse remodeling is not simply a mirror image of the molecular and cellular patterns that become dysregulated during forward remodeling, but rather reverse remodeling represents a coordinated multi-level process that allows the heart to adopt a new but less pathologic steady state that's associated with improved pump function and improved clinical prognosis, no doubt. However, many of the multi-level molecular changes that occur during forward remodeling remain dysregulated in reverse remodeling hearts, despite improvements in structure and function. So although they look normal to us as clinicians, they still remember or they have elements of a heart failure biology. And I think this is one of the reasons why these hearts continue to fail. So I've got a graphic, if I can advance my slide. Yeah, so this sort of summarizes what I think happens is you have a normal ventricle, there's remodeling, and with reverse remodeling, this ventricle comes close to, but never comes back to a normal. And the amount of heart failure biology that's retained in here, I think, would predict how fast these hearts will relapse when they're stressed again. So I want to try to put this together in a clinical construct that will be useful for today's symposium. And so Arvind asked me to sort of, how do we keep people in recovery and from relapsing? What are the clinicians supposed to do? You're at a crossroad. The first thing I can tell you is what not to do. And again, limited information here. There are the results of the TREAD-HF study. This was a phased withdrawal of pharmacologic treatment for heart failure. How they got this passed in IRB, I will never know. What they did was to look at people who had recovered their ejection fraction. They used a very stringent diagnosis or definition of recovery, including normalization of the ventricular size and a reduction in NT-proBNP. And then they were randomized 1-to-1 to phased withdrawal of guideline-directed medical therapy. Their primary endpoint for relapse was a decrease in EF by greater than 10%, increase in volume by greater than 10%, or twofold rise in NT-proBNP. The study was stopped prematurely. Within 6 months, 40% of people that we would have considered cured ended up redeveloping heart failure when the medical therapy was taken away. The primary reason was a reduction in ejection fraction. The secondary reason was the volumes were dilating. And I was pleased in the discussion, and I didn't review this paper and ask them to put this in, but they said, this finding suggests that for many patients, improvement in cardiac function following treatment does not reflect full and sustained recovery, but rather reflects remission, which requires at least some treatment to be maintained. So again, as part of this expert consensus panel, we tried to come up with some guidelines. Again, they're really not evidence-based, so I'm just throwing them out, open for discussion, about how clinicians should follow these patients. Again, this is a group of people on a telephone trying to come up with something useful. It's not evidence-based for the most part. So the first thing is to understand who's more likely to undergo reverse remodeling and recovery of ejection fraction. As I showed you before, non-ischemic etiology predicts it. Lower duration, I also showed you epidemiologic data on that. Women, for some reason, reverse remodel better. The absence of conduction system abnormalities predicts it. Surprisingly, there are a number of gene abnormalities like those in Titan that are not associated with the inability to recover. However, those gene mutations affecting Z-disc proteins and nuclear proteins tend not to recover. On echo, lower EF, absence of left LGE enhancement also predict recovery. And then, not surprisingly, lower biomarkers also predict recovery. So we tried to come up with a schema here, and I'd love to talk about this with Arvind and Guillermo. So we said that after the patient is diagnosed with recovered EF, we would recommend for the first 12 to 18 months that they be seen back in clinic every 6 months. clinical exam, repeat biomarkers, and we went out a little bit on a ledge here and just recommend echo with strain, because the decline in strain, at least in work from our group, predicts subsequent relapse from heart failure. After patients get out through that stability period, we would recommend that they be followed every 6 to 12 months with a clinical exam and at least an NT-proBNP. It's hard to make echo recommendations. I realize the echo guidelines don't really endorse echoing for stable EFs more than every couple of years, but certainly not at every year. And then we think for people who do have genetic abnormalities that they ought to get repeat Holter monitoring. A great many of them will develop recurrent atrial fibrillation, which could lead to deterioration. So this again is just it's in the paper. I'm not going to spend a lot of time on it, but this was sort of a schema for what we consider high-risk relapse people with imaging, EKGs, and biomarker levels. So what about the medical management? I think this is a complete up for discussion. So first of all, you got to realize that this is a very heterogeneous group of patients. And I've shown you the epidemiology. Virtually everybody can recover their ejection fraction. So I think your clinical approach should take into account the etiology of the LV dysfunction. We don't really understand anything about the medications that are required to maintain a sustained remission. My understanding is that the TREAD-HF trial is now systematically withdrawing ACE inhibitors, beta blockers, and then spironolactone to figure out which elements are required. Based on the results of the TREAD-HF study, and this is only 51 patients, we think it's prudent to continue guideline-directed medical therapy in these patients unless there are mitigating circumstances. And the reason for that is that relapse of heart failure is associated with recurrent myocyte injury, and that makes it harder and harder to recover if you do resume medical therapy. We do think that cessation of diuretics can be considered in some patients. And if heart failure recurs after stopping the diuretics, this is really a bad prognostic sign, and those patients should have up titration of guideline-directed medical therapy. I think these concepts are not new. It's always amazing when I go back and look in heart failure to realize how little I've contributed to the literature. So we've known about these concepts. This is just readmission rates from Lynn Warner Stevenson's group, but this early initial peak here, I'm having trouble with my, here we go, pointer. When they first come in the hospital, this is the period of reverse remodeling. Then we've learned really how to treat these people. And this period of reverse remodeling and improvement in ejection fraction, this is really the period of remission where patients stay stable. And then there's this other group of people who have relapse. And this, many of the people here, as I've shown you, will go on and developing worsening heart failure despite being on the best medical therapy that we have, which is kind of scary. So why is this stuff so important? Today, all hospital systems are being punished by these CMS guidelines, which say if you readmit patients with heart failure within 30 days, that you're not going to get reimbursed for that. And they attribute this to bad care. What I've tried to articulate this morning is I don't think it's bad care. I think it's bad biology. And the data for that are shown on this next slide, if I can ever bring it up. Yeah. So this shows temporal trends in readmission rates. And because of the CMS guidelines, they're certainly going down. But by the same token, you can see trends in mortality are going up. So I would argue that not readmitting these people tends to lead to worsening mortality and outcomes. So I want to conclude my talk this morning with a quote from Winston Churchill. This is not the end. It's not even the beginning of the end, but it's perhaps the end of the beginning. And I really think that over the last 30 years, we've gotten to the point where we can really treat these patients well. But now we have to understand why patients who ostensibly should be cured, they don't really have abnormal pumping capacity, and they don't really have abnormal size ventricles, why they redeveloping heart failure. And I think hopefully we'll come to some new answers in this in the coming years. So with that, I'll conclude. And again, thank Arvind and Guillermo for the kind opportunity to speak this morning. I wish I could be there in person. Obviously, these are strange times. So thank you again.
Dr. Mann, thank you so much for that lucid and wonderful elaboration on a very interesting topic. I want to remind all of our viewers to go to pollev.com or text to DeBakey to 37607. You'll have that information on the screen with whatever questions we have. A good amount of time for good, lively discussion. But Dr. Mann, I think as questions are coming in, I want to open by, I've heard you say this before about the LVAD mafia and heart failure mafia. I think we need to form a recovery mafia and really focus on this fascinating field. My question to you is, and yeah, I think we shared some discussions before. Our lab is also focused on recovery with a model a little different than your work, where we've looked at natural recovery once the injury is gone. And
right.
I always wondered if when you look at the mice that recover, we're looking at the differences between the gene expression of the ones that recovered compared to during heart failure. But I always wondered if the mice that didn't survive did not have the genetic ability to recover. So do you think there is a switch that makes some people recover more? Despite beta blockers, we see not all of them recover. What are your thoughts on, are we missing the boat by not looking at those mice that actually didn't?
So it's a really good question. So first of all, rats and mice are really genetically pure. So in them, it would be hard to cull out a specific gene defect. In people, there's tremendous heterogeneity in terms of who recovers and who doesn't. It would be, I think, hard to believe that there's not some genetic component to that. In my own simplistic mind, I think that the amount of injury that one accrues during the forward remodeling process does sort of predetermine how much you can recover. A simple example would be, if over time you progressively lose 40 to 50% of your myocyte mass, your likelihood of recovering is less. I mean, something has to make the heart get smaller. We don't have direct experimental data, but indirect experimental data, that if you look at return of contractility or return of contractile genes, it comes before the remodeling process actually occurs. So I think how you reverse remodel is also a really interesting question. I've spent a lot of nights up thinking about that, but it's not an elastic band that collapses. I think the sarcomere drives it, and then the matrix forms around it, which allows the ventricle to stay smaller. So I think if you can't get smaller, you can't reverse remodel. So the things that prevent that, certain genetic abnormalities for sure. And they've never done this, but I would predict that Titan abnormalities relapse faster. Again, that study's not been done. They certainly recover. And that people like the ischemics, like I showed you, where they have a myocyte deficiency, they don't recover as much. But in terms of the people who don't recover, who go on and die, I think it's probably going to be an admixture of missing components to recover, and then maybe some underlying genetic abnormalities. And we have no idea about how ion channels remodel in this. No one's really parsed that out. So it could be that certainly the ion channels don't recover and they're more prone to ventricular arrhythmias.
No, thank you for that. I think it to me, it almost gets overwhelming thinking about the complexity of recovery that goes on not just in the heart, the myocyte, the interstitial cells, and the systemic response. I think in that regard, we have a question here from the audience, and it's my partner, Barry Trachtenberg. He's saying, Dr. Mann, thank you for a phenomenal talk. I was wondering if the bioinformatics showed any role for ongoing inflammation as being more common in those that have not recovered.
Barry, hi. Good to see you. Not to see you, but good to hear from you. So there is a persistent inflammatory signature in one of our heart failure models. We've now detected chronic inflammation. There are more macrophages, despite the fact that the ventricles recovered. Vili Topkara, who was a resident at Baylor and then came with me to St. Louis, actually did a really nice meta-analysis of recovery transcriptional profiles and was able to show that one of the signatures of reverse remodeling was actually decreased in inflammatory genes. So he's got a really nice paper. I can't remember where it was published, but I would encourage you to look at that. So we think there's some evidence of chronic inflammation. I would love it if they were the ones that relapsed, and we're trying to test that hypothesis experimentally. But there is a certain reversal, and Guillermo has shown this really nicely with his earlier work, that unloading does lead to reversal of many of the inflammatory genes. In Guillermo's paper, it was tumor necrosis factor, but we see it all across the spectrum. Whether persistence of inflammation, low-grade inflammation, predicts relapse, we don't know, but a really good question.
I think with that, I'm going to see if Dr. Torre has some comments and questions. Inflammation in his field.
Yeah, so I didn't really want to push you into that field, Doc, but in understanding the biology of heart failure recover, and those that may relapse and those that may stay longer healthier, what would you think may be clues for designing interventions, or what is it that we really need to be looking at that may help us to design better therapies? Because at the end of the day, we'd like to maintain those healthier. And should we look more, what's your gut feeling? Is it more a myocyte issue? Is it the extracellular matrix and the fibrotic response? Are these peripheral humoral factors that affect how the heart is contracting in the interplay between myocyte and the extracellular matrix?
The answer is yes. So we've got another paper which we're trying to get through now, struggling a bit. But again, a resident, what we did was to look in our database at Barnes. We pulled out 1,000 people that recovered. And then we used machine learning to try to group the patients into different clusters. And then we're able to show that there were certain high-risk clusters and certain low-risk clusters. And the high-risk clusters did miserably. They were hospitalized or died. And again, in a large database like that, it's hard to have really accurate follow-up, which is one of the reasons we're struggling with the journals. But I do think there's a group of people, and not surprisingly, people who have conduction system abnormalities, and these were people that didn't qualify for CRT, but they did have a wide bundle branch. They were more likely to relapse. So I think my hope is that we'll be able to identify, based on clinical grounds, groups of people who are high risk, and then maybe get a better idea of the biology. It's hard, and I do think you could probably also come up with provocative tests. For example, look at contractile reserve with dobutamine or whatever, or figure out ways of looking at contractile reserve. The people who can increase their contractile performance with a stimulus would be more likely to withstand the hemodynamic stress. Those that can't, I think if they got stressed, would be more likely to relapse. So I think we need to do better clinically to identify these people, but I think there are ways of parsing it out. But I can't tell you which specific part of the biology is abnormal that predicts relapse.
So Doug, let me follow that with another question, which is maybe more a philosophical approach. But as you and Arvind and I and Barry have dealt with many issues, how do we bring new therapies to heart failure where now there is a number of medicines that are highly effective and more that are coming up, so that if we want to test, let's say that we come up with a new pathway, how do we test it, and how do we go about in testing it in humans? And if you look at this particular subpopulation of heart failure, I mean, is it going to be feasible to test new interventions in these groups of patients?
I think, right. So I would argue to that question that this is a group of people that have never been studied before. They're all on optimal medical therapy. Now, we don't know about SGLT2 inhibitors yet, whether that prevents it. But every single one of the patients that we talked about in the studies I showed you is on optimal medical therapy, and they're still getting heart failure. So this is different than developing a drug to prevent heart failure or to a new therapy to prevent heart failure or to stabilize it. It's a group of people who are on the best stuff we've got, right? And they still develop heart failure. And I think if you could identify the high-risk ones in there, you could come up with the trial to test either a new therapy, CBD. I don't know, but I think you could come up with a new therapy in that group of people. But the trick would be to come up with the really high-risk ones, because certain patients are probably going to do just fine, right? We know that not everybody on guideline-directed medical therapy comes back in the hospital, but about 40 to 50%, as I showed you in that Merlot slide, are at risk of redeveloping heart failure. And as I said, they're already on the best stuff we've got. So I think you can develop drugs in this space. I like you, worry about heart failure reduced EF, because I don't think there's going to be a whole lot of wiggle room after the SGLT2 story. Now it's just SGLT2 1 and 2, it looks like, based on what was just released at the American Heart. So there may not be a whole lot of room for developing new HFrEF drugs. But heart failure recovery EF, as I said before, they're failing the best stuff we've got. So that's my argument for why we need new drugs there.
So I think we have quite a few questions coming in, and I'll try to combine a couple of them related to GDMT. One of the questions was related to probably the TREAD-HF trial. They're asking, did the pharmacologic study specify which GDMTs were maintained or withdrawn? Which of the GDMT medications work best for maintaining recovery? And I think another question maybe related to the trial was, can we decrease or de-escalate GDMT for recovered heart failure with reduced ejection fraction?
Yeah, so all of these are really cutting edge questions. So first of all, they took everything away in a pre-specified manner, but I don't think they did one and then the other and the other. They just sort of reduced them quickly. My understanding is there's a TREAD-HF2 where there's testing which one you can remove, and then keep people on the other ones to see whether there's a constellation of drugs that are better. Chris O'Connor has talked about this concept of N-1 trials, where we, in a randomized way, would systematically take away one drug and then do outcome, take away another drug and do outcome. I think we need to do that, because if I'm a patient, at some point I'm going to stop wanting to take 5 or 6 medicines a day if I don't need them. Particularly if I'm really feeling well, if I'm New York Heart Class 1 and my EF's normal and you tell me I need to stay on 5 drugs, I'm going, why? Why do I need to do that? So we don't know yet. I think there are studies afoot that will address that. And as I said, I think where our field needs to go is this concept of N-1 trials. And as a clinical trial geek, I've really been enamored of some of these so-called platform trials that are going on in COVID, where they can test 10 therapies at once with a common control group. So what if you had a common control group and then you had one group with no beta block, take away the beta blocker, another group take away the ACE inhibitor, another group would take away spironolactone. You could design a large N-1 trial with a common control group and maybe get a readout in 6 to 12 months. It would be a really interesting study to do. No pharmaceutical company, by the way, will support this.
Yeah, no, absolutely. And I think that kind of brings to some of the genetic aspects, and there are 2 questions which I can combine. in asking about which cells will be the primary target, either cardiomyocytes or fibroblasts or extracellular matrix or immune cells. And related to that, should we be talking about a single gene pathway or should we be aiming at multiple gene pathways?
Yeah, so I'll address the second question first. We know from studies that certain gene defects will prevent patients from recovering their left ventricular ejection fraction. So based on that, I would think looking at a single gene pathway might be more instructive. Which cell types are critical for reverse remodeling? I don't know. As I said before, I think the myocyte is the sine qua non. You can't get a smaller heart unless the myocyte gets you there, right? But is that the thing that predicts relapse? I will say that in many of the reverse remodeling models, that the matrix doesn't change a whole lot. The caveat there is these are short-term studies in mice and rats, and the matrix may take 3 months to remodel, and we're doing this in a study in a month and a half. So it may be that the matrix is more important. So I think it is multi-level, right? I don't think it's going to be one thing. Initially, when I got into this, I thought, oh gosh, we're going to find a single gene defect, and we're going to be able to tweak that gene defect and then come up with a way to make everything better. It's so complex, and I showed you on this transcriptional profile plots, it's not a single gene pathway in the myocyte. The matrix is abnormal, the integrins are abnormal, the EC coupling is abnormal. All the elements of the myocyte are abnormal. A few things get better in the sarcomere.
Just find a comment if you.
So, if you wanted to find a specific target for recovery, I don't think you can. It's way too complex. Hopefully that sort of answered the question, Arvind.
I've always wondered all those questions that our audience asks. I'm very refreshed to see a very engaging and well-versed audience that are asking these questions. One other question, probably kind of, I don't know if there's enough evidence, but somebody is asking, does regular exercise improve genetic signature that promotes recovery?
Really a good question. There was only one really organized study that looked at this, NIH-based study that looked at the effect of exercise. And what they were able to do was show reduced hospitalizations. Now, those were all heart failure reduced EF patients. I don't know what their EFs were at the time that they were exercising, but if one were to extrapolate from that to the current day, if somebody said to me, would exercise be beneficial? I would say, yeah. The one thing that we know from that NIH-based study was that it did prevent hospitalizations. We just don't know what the EFs were while they were exercising. I would suspect a certain cohort at the time of randomization may have had reduced EF, but by the time they were treated 2 months later and then in exercise regimens, they may have had recovered EF. So I think exercise does so many good things. It does unload the heart. It does reduce reactive oxygen species through enhanced nitric oxide generation. So I think it's the answer I would say is yes, but I can't give you a specific randomized trial. All I can do is extract or extrapolate from a prior one in whom they probably had some HFrEF EF patients in it.
Thank you, Dr. Mann. I think your last slide of your presentation was very appropriate, that we have a lot to achieve, and it's a fascinating area where we can probably, as you mentioned, we should plan on a recovery mafia, so the field really gets to a point where in essence you're imagining a day where we don't have to prescribe our patients 15 medications. As excited as we are as cardiologists, heart failure cardiologists, seeing new medicines, trying to modulate a set of genes to recover versus medicine sounds very lucrative.
I think we're going to get there, Arvind. I really do.
No, I think that
So count me in for the LNAD Mafia. I'll pay my dues now.
Absolutely, absolutely. I think I was going to ask you to start it so we can be the members of it. But thank you again for your time today. As we come to the closing, I want to again guide all of our audience that the George P. Noon Conference will continue in a different link, and you can definitely find it on our website if you look for the George P. Noon Conference, where we have an exciting day focused on advanced heart failure, followed by durable mechanical circulatory support, and then followed by transplant. After this grand rounds, the next session will be kicked off by Dr. Ashrit Guha, who's the co-director for the transplant program, pulmonary hypertension, and advanced heart failure cardiologist. And as we wrap up, I'm going to let Dr. Torre kind of give some closing remarks, and we'll end.
Thank you, Arvind. So, Doug, I cannot stress the fact that that this was a beautiful example of how to bring basic fundamental concepts that will open up the path for more translational and clinical research work, which is really so exciting, and it's been perhaps one of the greatest motivation to continue to work in this field. And I kind of wanted to highlight that for maybe the fellows in the audience or students or younger cardiologists that are in the field, that I think they witnessed an example, even though Doug was very humble and didn't say that, but this work represents a very deep and thoughtful insight into not only the biology, but also the clinical setting, which is really not easy to obtain. And I think that I kind of wanted to highlight the importance of, for many of us that are continue to work in this field, the importance of understanding biology, but also the clinical perspective, that it makes a fundamental difference in how we approach the illness and how do we bring new therapies to patients, which at the end of the day is what we all want to do. So Doug, it was really terrific, great to see you. And as always, a beautiful and extraordinary lecture. Thank you for your time and sharing everything with us.
Yeah, no, again, thank you guys. It's so great to be with you this morning. And as I said, I wish I could be there in person. So be safe, everyone. Be safe.
Thank you. You too.